Welcome to the MTQIP 2025 Definition Updates video. This video provides a concise review of the changes for 2025 admissions. The first part reviews changes implemented by the NTDS. The second part pertains to MTQIP specific changes and clarifications. Before we begin, let's review the format key. A variable name with a yellow highlight signifies a new variable or definition. Red text signifies verbiage that is specific to MTQIP and varies from the NTDS or TQIP data dictionary. Text with a strike-through signifies deleted or retired verbiage. Black bookmarks with a database icon indicate vendor-related changes for action or attention. Red bookmarks with a computer code icon indicate analyst-related changes for action or attention. Lastly, if you'd like to spend more time on a variable, push the spacebar to pause the video. Let's get started. Changes have been made to several data elements in order to stay in line with the 2025 NTDB or TQIP data dictionary. Patient inclusion criteria has been updated to include patients transferred or discharged to hospice care. This includes outpatient hospice facilities, inpatient hospice units, and home hospice. The data element sex has been retired to align with the NTDB data dictionary changes. The new data element, sex assigned at birth, has been added. The new data element of gender has been added to capture a patient's gender identity. The new data element, gender-affirming hormone therapy, has been added. This includes patients who have received hormone therapy due to gender transition within 30 days prior to ED or hospital arrival. Please exclude patients who are undergoing hormone therapy for any other medical reason. Reporting of the incident city has been changed from the city or township where the patient was found or to which the EMS unit responded to the city or township a patient's injury actually occurred. This gives a more detailed description of where the mechanism of injury actually took place. This element is only reported if the incident location zip or postal code is unknown. Reporting of the incident state has been changed to the state, province, or territory where the patient's injury occurred. This is also only reported if the zip or postal code is unknown. Reporting of the incident county has been changed to the county or parish where the patient's injury occurred. Reporting of the incident country has been changed to the country where the patient's injury occurred. NTDB has added a new variable of intubation prior to arrival. MTQIP has included this data element as well to align with NTDB. Please note that the inclusion-exclusion criteria differs from MTQIP's data element of intubation status or first intubation location, which is not being changed or retired to allow for continuation of this historical variable. MTQIP has not altered the new NTDB data element of intubation prior to arrival to make capture easier for abstractors. NTDB has added a new variable of intubation location, which specifies out of hospital versus transferring facility. This is only reported if the patient meets the capture criteria of the new NTDB data element of intubation prior to arrival. MTQIP has included this data element as well to align with NTDB. Again, MTQIP's data element of intubation status, which captures the location of a patient's first intubation regardless of whether it was prior to arrival or at your facility, remains without change. For the data element of ED discharge disposition, a few changes have been made. Hybrid OR has been added under the existing element value 7, operating room. New element values 12, interventional radiology suites, and 13, hospice, have been added. The new variable of primary medical event has been added. This element will help provide a more accurate picture of the patient's mechanism of injury if initially caused due to a medical event such as a seizure or MI. For example, if a patient has a seizure while driving, which in turn causes the MVC that brings them to your center, this variable will help identify this occurrence. The new pre-existing condition of autism spectrum disorder has been added. This includes the diagnosis of autism spectrum disorder, or Asperger's. The new variable of bronchopulmonary dysplasia, or chronic lung disease, has been added to the pre-existing conditions. This includes patients with cystic fibrosis only if there is pulmonary involvement. This variable is only to be reported in patients less than 15 years of age. The new pre-existing condition variable of ventilator dependence has been added. This element captures trauma patients who are ventilator dependent with a tracheostomy prior to injury. For pre-existing conditions that have the inclusion criteria of only reporting on patients that are greater than 15 years of age, there is the new inclusion criteria of reporting based on the patient's age on the day of arrival to your hospital. This includes variables such as alcohol use disorder, substance use disorder, COPD, and most of the psychiatric diagnoses as listed. Hospital discharge disposition additional information has been updated in a few areas. This includes verbiage-only changes regarding UB40 disposition coding, replacing the words based upon UB40 coding to adapted from UB40 coding. There is also the addition of the instruction that disposition to any federal healthcare facility must be reported by selecting the option that most closely aligns to the needs of the patient. For example, if a patient is discharged to a Veterans Hospital skilled nursing facility unit, this would be reported as 7, discharged to a skilled nursing facility. An update to report not applicable if ED disposition is 13, discharged or transferred to a psychiatric hospital or psychiatric distinct unit of a hospital has also been added. For highest Glasgow Coma Scale total, motor, and assessment qualifier, there is just a verbiage change that adds, for patients who are at your hospital on the calendar day after ED or hospital arrival, the null value of not known, not recorded is reported if reporting Glasgow Coma Scale 40. The verbiage of, for patients who were discharged from your hospital prior to the next calendar day after ED or hospital arrival, the null value not applicable is reported. This is not a reporting change, merely a change in wording to keep in line with the NTDB changes. The verbiage for highest Glasgow Coma Scale 40 motor has been changed to mirror the changes to highest Glasgow Coma Scale total. This is also a wording change and not a change in reporting practices. In the following slides, we will look at MTQIP updates that do not reflect changes made by NTDB and TQIP. Trauma center names are updated yearly based on information provided by individual centers prior to the data dictionary being released. If MTQIP is made aware of name changes after this time, they will be updated in next year's data dictionary. Please note that a center's ID, for example, UM, SJ, WB, etc., will not change for consistency. For trauma surgeon, coding has been removed per ESO suggestion and does not affect the way a center reports this information. For the data element of drug screen, verbiage has been added specifying that unconfirmed positive drug screens within 24 hours after the first hospital encounter should also be used for reporting. Recently, more hospital labs are using this type of lab result for medical purposes, and more detailed labs are not run unless confirmation testing for individual drug class is requested for non-medical purposes such as legal requests. ED discharge date description has been updated to the date the patient was physically discharged from the ED. This is for clarification purposes and includes patients who may be ED holds prior to being transferred to an assigned bed. This best provides a true picture of the patient's actual hospital stay. If a patient expires in the ED, we have added the instructions to use time pronounced and not time expired if there are 2 different times charted in your EMR and no death certificate is available. This is something we have seen with a few centers this past year. According to the Wayne County ME's office, time pronounced is the time they use as time of death. ED discharge time has been updated to correlate with ED discharge date. Please report the time a patient physically leaves the ED. Time of death also correlates with the ED discharge date change regarding using the time pronounced as the time of death if there are two different times reported and no death certificate available. Clarification has been added to the data element of intubation status. This clarifies that regardless of what facility a patient is intubated in, the location is to be reported. For example, if a patient is intubated in an outside hospital ED and is then transferred to your facility, you would still report 3 ED as the location of first intubation. For anticoagulation therapy, the wording IV only for heparin reporting has been removed, as IV and sub-Q heparin have a similar half-life. For the pre-existing condition of ADD or ADHD, where the description notes a disorder involving inattention, hyperactivity, or impulsivity requiring medication for treatment, criteria has been added to include patients with the diagnosis when there is documentation that patient has meds prescribed but is non-compliant. This is a common scenario with psychiatric type meds, but does not negate the diagnosis or symptoms if not treated. If you find a diagnosis alone without documentation of prescribed meds, please continue to exclude. This aligns with NTDB TQIP reporting. With new injectable medications being used to treat diabetes, the description has been changed to diabetes mellitus that requires treatment with the medication to lower control glucose or A1C levels. This includes GLP-1 agonists, which are a class of medication that mainly help manage blood sugar or glucose levels in people with type 2 diabetes. Examples include Ozempic, Trulicity, and Rybelsus. These new meds fit within the desired scope of the definition of diagnosis present and pharmacological intervention being utilized. Exclude patients using this type of medication for weight loss alone without the diagnosis of diabetes. Please note that this change does not coincide with the NTDB definition. In line with the drug use definition, the pre-existing condition of substance use disorder has the added clarification to include unconfirmed positive drug screens for non-prescribed drugs. MTQIP has also added using positive autopsy drug screens for substance use disorder if capture criteria are met. Starting January 2025, AAAM 2015 injury coding is required for AIS injury submission information. For the hospital event of alcohol withdrawal syndrome, clarification has been added stating that this complication may occur approximately 6 to 48 hours after alcohol cessation and usually abates after approximately 2 to 5 days. The times included were guidelines and not concrete time frames. This is another area where the true picture of the patient is the goal. For the hospital event of stroke or CVA, the wording of no other readily identifiable non-stroke cause, such as progression of an existing traumatic brain injury, seizure, tumor, metabolic or pharmacological etiologies is identified, has been moved from the second data box to additional information. This was done to exclude patients whose neurodeficits are greater than 24 hours, but cause is something other than a stroke or CVA. Hospital discharge date has been updated in the same manner as ED discharge date for patients whose final disposition is deceased or expired. This clarifies the use of date pronounced over date expired if no death certificate is available and both are documented in your EMR but differ. Hospital discharge time has also been updated to clarify the use of time death pronounced over time expired if no death certificate is available and both are documented in your EMR but differ. For Glasgow Coma Scale Assessment Qualifier component of highest Glasgow Coma Scale total, the element value of E, obstruction to I, has been removed. Antibiotic type 2 has been changed to match the element values of antibiotic type 1. This will not change the way this element is captured in the trauma registries or in the validation forms. Opioid quantity has the added clarification to exclude refill prescriptions written for on discharge. This most likely won't be seen, but in the occasion that it is, please do not include. The element value of unanticipated mortality with opportunity for improvement has been removed from the mortality classification data point. Under the ICD-10 hospital procedure codes, TPN has been retired as required reporting. Centers may continue to capture this procedure for their own use, but it will no longer be required by MTQIP. This slide shows where the TPN change is made in the data dictionary. Beta blocker treatment for patients with at least one injury in the AIS head region is retired starting in 2025. Reporting IV fluids pre-hospital and in the first 4 hours is retired for 2025 case reporting. Reporting IV fluids in the first 24 hours is also retired for 2025. The next slides will review new VTE prophylaxis data elements added in the 2025 data dictionary. Please note that reporting for the following data points are not required until July 1, 2025, to prevent abstractors from having to backtrack cases while 2025 ESO updates to registries are being completed. The first new data element is venous thromboembolism prophylaxis strength for patients receiving low molecular weight heparin or Lovenox. This is the strength in milligrams of the first dose of Lovenox administered to the patient at your hospital. Report the low molecular weight heparin strength regardless of the indication when it is administered first. Please round to the whole number. Venous thromboembolism prophylaxis frequency is to be reported on all patients receiving low molecular weight heparin regardless of the indication when administered first. Report the number of Lovenox doses administered in the 24-hour period after a patient's initial dose at your hospital. Please pause this video and review the included examples for reporting guidelines. Data elements regarding VTE prophylaxis prescribed upon discharge have also been added for 2025, with required reporting starting July 1st. The first variable is the VTE discharge type. This refers to the type of VTE prophylaxis or treatment prescribed to a patient on discharge. For VTE discharge type, please report Coumadin, heparin, Lovenox, direct thrombin inhibitor, and 10A inhibitor class agents regardless of the indication. This differs from the inpatient VTE type reporting by including Coumadin regardless of indication. Report low molecular weight heparin when patient is discharged on a Lovenox to Coumadin bridge. Please continue to report aspirin and other agents only when documentation indicates they are being prescribed as VTE prophylaxis. Exclude non-prophylactic dosing of agents, such as heparin administered for line clearance purposes. Venous thromboembolism prophylaxis strength is the strength in milligrams or units of VTE prophylaxis or treatment prescribed at discharge. Please report the prescribed strength of Coumadin, heparin, Lovenox, direct thrombin inhibitor, and 10A inhibitor class agents regardless of the indication. Again, exclude any non-prophylactic dosing of agents, such as heparin administered for line clearance purposes. Venous thromboembolism prophylaxis discharge frequency is the frequency per day of VTE prophylaxis or treatment prescribed at discharge. Please report the frequency of Coumadin, heparin, Lovenox, direct thrombin inhibitor, and 10A inhibitor class agents, regardless of the indication. For venous thromboembolism prophylaxis discharge duration, report the days of VTE prophylaxis or treatment prescribed at discharge. Like the previous data elements, report Coumadin, heparin, Lovenox, direct thrombin inhibitor, and 10A inhibitor class agents regardless of the indication. If the duration is ordered in months, calculate 1 month as 30 days. For example, if an order is written for Lovenox times 2 months, please report 60 days regardless of how many days are actually in the months that the patient will be using this med. Thank you for watching. We hope you found these updates useful.